A lot of the data that is being collected are proxies, which really are indications of what might be there, not of what actually is. Some of the things on what transplant centers and surgeons really want to know: age, hypertension, diabetes, these sorts of things. The study that is typically being asked for is the heart cath. And when we ask why, it goes into the coronaries. There are novel ways to get the data around coronaries that are not through the gold standard of the heart cath.
I personally can attest to several scenarios where in the process of vetting a donor heart, a prospective DCD donor heart, and because some of these high risk criteria were in play, and being told, well, we understand you would want a donor heart cath, but we can't do it. It's not possible for this donor because they're DCD. That led to countless declines, or just can't even pass go, where those donor hearts were not even being evaluated. And in this really provocative study, in about 80% of those scenarios, the heart was not recovered or used. Only 15% were actually transplanted. For comparable scenarios where we otherwise would have used the heart, we're talking about up to 1,200 DCD hearts that probably were usable. That is a huge figure. And really, the fact of the matter is, the data is already there in the vast majority of cases. We're not talking about a super exotic type of evaluation or a scan. And I firmly believe that the inability to get a cath in a given donor should not by any means mean that donor heart can't be offered. It certainly can.
There is a treasure trove of imaging information in hospitals across the country. And when you have a potential donor and you need to know, is it thumbs up, is it thumbs down? Are there things that will rule out using that donor? There's an efficient pathway to get there. And it may be using imaging that is already available in that institution. It may be supplementing that with an additional CT scan. What's really interesting about this project for me is working with CompuMed and working with these centers. How can we do this quickly? How can we do it efficiently? And how can we do it with great accuracy? To use a baseball analogy, I think what we're saying is that there's a way, you're not trying to bat 1,000, but you're trying to use imaging to significantly increase your batting average. And I think that there's an ability to do that with advanced imaging, certainly on the cardiac side and as well as on the abdominal side.
What all of this is about is make it so that the transplant centers are not surprised when they come, and they don't have a regret if they don't come.